Let's talk about something I see quite often in my clinic, which is postmenopausal bleeding. If you've gone through your menopause transition, which means you've gone through menopause, meaning 12 months without menstrual bleeding, um, and now you're having bleeding, well, you're going to want to see your doctor, and here's why. My name is Eric Schmidt. I'm a board certified OBGYN, minimally invasive gynecologic surgeon, talking a lot about different issues surrounding menopause. And bleeding is one of the most common issues that I see in my clinic, and it certainly needs a workup and an evaluation. And so please stay tuned. It matters where you get your information here at the New School OBGYN. So we're going to go over postmenopausal bleeding, or PMB, we call it. Okay, so postmenopausal bleeding. Now, it definitely can be scary for some because I know the thing we want to rule out is something like precancer or cancer. And often we're doing that with a biopsy. We'll talk about that a little later on. But actually, I wanted to give some reassurance because most often it's not something like that. Now, most often, postmenopausal bleeding is often caused by things like polyps, other issues that there can be when someone's more in the menstrual years. This is pretty common. Or things like atrophy. And now atrophy means that the tissues are thinning, meaning that the estrogen decrease from the ovaries and the hormone decrease from the ovaries, the vaginal tissues, the cervix, uterine tissues, they like that estrogen, and so they're just a little less resilient. They bleed easier, and so this atrophy bleeding sometimes can be like a little bit of bleeding spotting in menopause. Generally, it's not heavy bleeding, but that's a different cause. Or sometimes we call it proliferative, and this would mainly be like, the ovaries are still making intermittently enough hormone to give somebody resemblance of a menstrual period, because the ovaries actually, they don't stop producing hormones right at menopause. There's no abrupt, one day you're producing hormones, next day you're not. Actually, there's this steady decrease through a woman's later menstrual years, and there's a line where the periods really stop, and so you cross that line. But sometimes ovaries kind of, they peak up, and so they might go above that line, maybe giving enough hormone off to signal to the uterus to start that proliferative phase again. So that's often that proliferative finding, if you might see that on a biopsy result. There can be things that, again, common issues for women. A lot of women have fibroids, and so those can be kind of resilient to some of that hormone decrease, and they can still try to draw blood to the uterus even in menopause and potentially give a little bleeding off. And so fibroids definitely an issue that we see commonly, that commonly can cause some issues with bleeding after menopause. But then again, we're getting to more of the things that we want to rule out, which it would be like, we call it hyperplasia. Can't spell. And then things like cancer, endometrial cancer specifically is what we're talking about. And so actually, these different things, they, just to break down how often they happen, polyps happen about 35% of the time when someone's coming in with bleeding. This might be an issue. It's usually a little bit more menstrual-like, intermittent. It's not just spotting, because that's often things like atrophy. If someone's coming in, they're having a little bit of bleeding, they're maybe 10, 20 years after their menopause, they've been without that estrogen for a while, there's a higher chance of things like atrophy, or usually it's a small amount of bleeding, not heavy bleeding. And unlike the proliferative, which is often a finding about 15% of the time on biopsy, that is more of like a menstrual type bleeding, often with that proliferative bleeding. And just to break it down even further, fibroids are often a cause. It's hard to put a number to the fibroids. But hyperplasia or cancer, this is only about 6% of the time, 6 to 9% of the time, that when someone's coming in with postmenopausal bleeding, that it is something like cancer. And so hopefully that number is a little less than you thought initially, but that is still a high percentage. And so we're going to be going through the how we work that up, rule this out, to keep you safe from this. Okay, so patients coming into my clinic, they had bleeding, and either myself or the primary care provider is often ordering an ultrasound to evaluate for some of these causes. Just like if someone's having bleeding irregularities in their menstrual years, we want to rule out other things like polyps, things like fibroids, and the ultrasound can help us do that. But specifically, what we're going to be looking at is the uterus and the lining, the thickness of the lining, because that'll help direct us for the if we need to do something called a biopsy, which we alluded to before. But the uterus kind of looks like a pear-shaped organ, vagina down here. This is the lining. This is where the bleeding builds, and then it sheds and comes out. Okay, and so this is the thickness here that we're looking at. Is this line really thick? Okay, that would lead us more to wanting to do the biopsy. Or is the lining very thin, meaning that there's a higher chance of something like atrophy that's causing the bleeding? And so we have some specific numbers which you look at, and if the endometrial thickness, we'll call that ET, is greater than 4 to 5 millimeters, we're probably going to be recommending doing that biopsy to rule out the scary causes, because actually they found that if the endometrial thickness is less than that, so less than the 4 to 5, the chances of things like endometrial cancer, hyperplasia is significantly lower, and actually pretty darn rare. And so sometimes in those situations, we often are thinking, okay, that might be more of the atrophy. We don't need to put someone through this potentially painful procedure because we're fairly confident that it is a benign cause. But if somebody does have the thickness greater than 4 to 5, I don't want you to worry thinking, oh my gosh, it is something like that. But we do want to do the biopsy to rule it out. And I think I just want to make a quick point about this too, because as now I've been doing this for a little while, making a few videos, I have definitely seen some people say, oh, don't get this done. It's the worst procedure ever. And we're going to talk about how to make it better and other options you may have for pain control. But I really discourage those patients saying those blanket statements saying something is so bad. But no, we're trying to rule out some pretty bad things here, okay? And so the biopsy, we can do better in our profession to make these procedures better for women that are going through them in the clinic. And if you want to check out our podcast that I did with Dr. Valieva, which we did just a little bit ago, talking about how to make in-office procedures better, like things like IUD or endometrial biopsy, please listen to that video. It might help you out. Again, we're going to talk about the biopsy a little more. Just wait a second. We're going to talk about a couple other points. So actually, quite a common consult that I get is a patient is getting evaluated for something else. They do a CT scan, they do an ultrasound of the pelvis, and they see that the lining is thickened, and then they're 10 years from menopause, and they're like, well, I haven't had any bleeding. Actually, for these patients, I say, yes, go in, talk to us, get evaluated, but there's a chance we might not even have to do this biopsy, because the most common symptom that someone may have with hyperplasia or malignancy of the uterus lining, the endometrium, is bleeding. If someone doesn't have bleeding, but the ultrasound or CT scan says it's thickened, you have an option. I'm less saying these patients need the biopsy. For some of the cases, I don't believe that they do. It's just kind of an incidental finding, and sometimes CT scan isn't so good at measuring the thickness of the uterus. It's just not good at that. It can have more error. And so talk with your doctor if by chance you have the thickness, but I wouldn't worry as much in that scenario. Okay, let's talk about the biopsy itself. Now, the biopsy is often done in the clinic. There's this little pipette, which during a pelvic exam, like somebody's getting their pap smear done, and getting the pap smear done is often things that we're catching somebody up to date on if they haven't got it done recently, because that can cause some bleeding issues from the cervix, along with all these other causes. And I guess maybe we'll talk about there are other causes within the vagina. The little micro tears can happen around the urethra, the opening of the bladder where the urine comes out. That can, from the lack of estrogen, can have what's called a urethral caruncle, or bleed really easily and have the strawberry looking lesion there. That's a benign thing. It's just often from the lack of estrogen in the area, and that inside kind of coming out like that. But yeah, there are other things we're going to be looking at during that exam, and catching you up on your pap smear potentially. But the biopsy is a procedure where a little pipette, very thin, actually thinner than the insertion device for an IUD, goes up through this cervix, which we'll talk about. That's the most uncomfortable part, up into the uterine body, and it creates a little suction. So it's not a biopsy where somebody gets, like often biopsies, you cut into tissue. This just sucks out the free-floating tissue within the endometrial lining. What I often reassure patients is that it only takes about 5 to 10 seconds of that bad cramping. I never underestimate how significant this cramping can be for some. Now, some people do really well with it. Often these are people that have had things like vaginal deliveries before, that cervix has been opened before from something like that. And so, but it's different for everybody, and especially for someone that's been through menopause for a while. The opening of that cervix can be quite tough and stenotic, we call it, and might need additional help to open up to allow that little flexible pipette through. And so definitely talk about pain control options with your doctor if you think you might need them, and honestly, you deserve them. And if someone knows they have a really difficult time with pelvic exams, with anything like this, with their cervix being touched, let your doctor know. Hopefully, they can make adjustments to the plan for you. And you can proceed with something called hysteroscopy, which is often done under anesthesia. Or again, look at our podcast video with Dr. Valieva. We talk about other in-office things that we can do to help make this procedure a little more comfortable, because it can be significantly crampy. But we can work our way around that, because again, if we're recommending this, it's because we're worried enough where we think it really needs evaluation to look out for those things. And hopefully the biopsy gets done nice and easily, and it shows that it's one of the benign causes. And another question real quick before we finish is, well, what now? Often, if it's benign and the bleeding isn't troublesome, we can kind of wait and see if this bleeding recurs, because if it recurs, we might want to do that thing called hysteroscopy, go in, look to see if there's something like a polyp hanging out there that can be easily removed, and hopefully resolve this issue so you don't have to worry about it anymore. I hope all this helps. I hope it gives some reassurance about the potential plan you may have for the bleeding after menopause. Again, most likely a benign issue, but we just need to see you to evaluate fully to figure out and reassure that it is. And I hope you enjoyed this video. If you want more videos like this explaining procedures in the office, let me know. Or if there's something else you want to explain more, leave it in the comments, everybody. Have a good day. Have a good holiday if I don't talk to you before then. All right, bye-bye.